A very good morning to one and all. Indeed, it's a privilege and pleasure to come to UROFAIR again and to share the podium with a wonderful friend, Professor Azari from Singapore General Hospital. We are going to enter into this next phase where we talk about urolithiasis, and we have three very excellent speakers. All three, I think, are pre-recorded, so we can ask questions at the end of the session. I'll hand the mic over to Azari to introduce our first speaker and first lecture.
Hi, good morning, everyone. So our first speaker is Dr. Banakich Lojana Piwat, who's a surgical urologist at the Chiang Mai University and Chiang Mai Ram Hospital. He's board certified in endocrinology, and his specialties include surgical urology, the aging male, and erectile dysfunction. He holds memberships in the Thai Medical Council, Endoscopic Society, and Society of Aging Male of Thailand. And his talk will be on pros and cons of miniaturization in PCNL. Dr. Banakich, please.
So, Mr. Chairman, ladies and gentlemen, I would like to thank the UROFAIR for this year to invite me to join the session of the UROFAIR for this year. So, I am a representative of the TUA. That my topic today is the pros and cons of miniaturization of the PCNL. It's small. It looks like the mini perk. So, what can we do that for the topic? So we have the question that is smaller or way better. We have to question all the time about the small size of the PNL compared with the standard PNL. So if you look for the PNL percutaneous nephrorectomy, for the EAU guideline, the treatment of choice that for the PNL is a large and compact renal stone. It's because there is a higher layers of the stone kaolin compared with the shockwave or RIRS. And also, but it's just not the higher layers of the stone kaolin, but the problem with the risk of the bleeding, infection, and the other post-operative morbidity. So if you look for the guideline, the PNL is for the big stone. So the trend of the minimizer of the percutaneous tract size have been noted in the PNL for the renal stone. The management shift from the open surgery to standard PNL, mini PNL, and the last set is Untitled and micro PNL technique. So if you look for the evolution of the timeline of the recent innovation in PNL technique, so they come from in 1998. It's for the position followed by the endoscopic guide access that are overcome by the ultrasound or the full fluoroscopic guidance. And right now they talk about the size of the instrument that from mini to micro and untitled. That is the key for the talk for today. So terminology of the PNL and mini PNL. So if you look for the procedure standard PNL, mini PNL, super mini, micro, or the other. The difference is for the sheet outside diameter is very important. So standard PNL is the size is more than 22, and the mini PNL is less than or equal for the 22. The super mini is 10 to 14, and the other is smaller and smaller. So today I'm going to talk more about the mini PNL compared with the standard PNL. So specific indication for the mini PNL, so that the small size PNL is for the stone in the diverticulum or stone in the small collecting system, spirally collecting system, high volume of the kidney stone in the children. If you look for the anatomy of the children is smaller than the adult, the previous failure of the ESPL or URS for the upper ureteric stone or the hard stone that the cystic stone. Anatomy abnormality precluding retrograde access that we cannot do the retrograde access RIS. That is the indication also. And the patient with the narrow or long infundibulum or at the secondary access for the accessible or retained stone resulting for the standard PNL. So this is the indication for the mini PNL. So if you look for the main characteristic of different renal PNL technique, so the outside sheet is different from the conventional to mini for the micro or micro PNL. So the outside, there's the difference between them. And also the tract dilatation is different also. So this is also that we have to know that the technique of the PNL from the standard mini or micro PNL. So the other instrument that we see for the picture, the standard PNL is quite big, more than 22, mini PNL less than 22, and ultra mini is smaller, maybe less than 14. So the micro are on the right side of the picture. And the other thing that you have to know that for the irrigation, that's very important for all the technique nowadays. Irrigation and mini PNL, irrigation that the key of the success of the micro or the small mini perk, the vacuum cleaner effect is very important. Any fracture lead to poor drainage, temporary elevation of the intrarenal pressure, that the pressure more than 30 millimeter mercury, that there may be the problem with the fever, follow the technique. And also that as the diameter of the access sheet decrease, they also have the chance to increase of the renal pelvic pressure and absorbing of the irrigation fluid. So the problem to get the fever after the surgery. If you have the surgery time more than 60 minutes, 60 seconds with the renal pelvic pressure is more than 30 millimeter mercury, that may be the chance of the fever and also the sepsis. Also, the vacuum assist mini perk is a new of the fragment clearance intrarenal pressure control. If you look for this slide, that the higher of the intrarenal pelvic pressure is high when you put in the cost system. But if you look for the vacuum laplexy, that's the mean of the intrarenal pressure will be decreased compared with the standard or cost system. The comparison of the current technique that the dilatation from the PNL and mini perk. PNL, the standard need the multiple step, but the mini PNL just only single step. And also the difference in this indication of the stone and the technique of the stone removal. And also that you see for this, the transfusion rate is less in the mini PNL compared with the standard PNL. And also that the stone fee in the current literature, they call that the stone fillet are the same in both techniques. The first single center RCT report in the year 2010 that we call that compare with mini PNL and the standard. The fever is not different between both of the technique, but the decrease of bleeding is more in the standard PNL compared with the mini PNL. And also that if you look for the stone type, if you have the multiple of calyceal stone, is the mean operative time and stone free is better in the mini PNL. In the year in 2015, that they have the meta-analysis that can stain the evidence of the PNL compared with the standard PNL, including of the 10 of the study. And with the track of me PNL is the track more than 10 and less than 18 Fen. So if you look for the outcome with the stone fillet, they call that the two technique is the same, but hemoglobin decrease is less in the mini perk, but transfusion also less in the mini perk, but ovulative time is longer in mini perk compared with the standard PNL. In this the meta-analysis study. And also for the hospital stay, it's shorter in the mini perk, but the fever population may be the same in both techniques. But if you look for the visual analog scale, that for the quality of life post-operative, the people or the patient select that the mini perk is better than the standard PNL. From the review of the EAU, they studied for 18 studies, including up to RCT and 10 case series altogether for the EAU for the meta-analysis. So if you look for the stone fillet, both technique for the standard PNL and mini perk is not different between two techniques. And the decrease in the hemoglobin and also decrease in the percent of the drop of the blood, they prefer the mini perk better than the standard PNL. And also duration of the procedure confirm that it's longer or ovulation time in mini perk compared with the standard PNL. So standard PNL, they have a shorter of the operative time. Length of the stay mini perk is better than the standard PNL. And also in the recent meta-analysis in the 2021, that are only RCT and prospective study compared with the mini perk and also standard PNL. Altogether that show to evidence base that compare from Turkey or also China and also many countries that compare in this study in this meta-analysis. So if you look for the outcome that both technique is not different in the mini PNL and also standard PNL, but the operative time we prefer the standard PNL is the shorter our operative time compared with the mini PNL. And also if you look for the visual analog score, mini perk is better than the standard PNL. How for look for the mini perk compared with the standard PNL? If you look for the detail, the stone fillet, they have the same stone fillet compared with the standard and mini PNL. It depending on the technique of the puncture, tag dilatation, and the energy used to the fragment of the stone. Mini PNL is more effective for the small stone rather than the larger stone more than 2 cm. No evidence for the support of the upper limit of the mini PNL. So this is also the stone or the result of the PNL compared with the standard PNL and a stone burden impact of the stone fillet in the mini PNL. So the stone burden is the key factor of the safety and efficacy. If you look for the stone simple or the complex stone, significant shorter operative time, less hemoglobin drop, and high stone fillet after single section of the mini PNL compared with in the simple stone. Complex stone standard PNL may be better in the stone fillet compared with the mini perk. And a simple renal pelvic stone and low volume staghorn stone, the efficacy of stone fillet is not different between standard and mini perk. So this is adjust for the number of tag and PNL session. So operative time that the major disadvantage of small instrument, especially for the mini perk, operative time, stone fragment removal, stone burden, and type of the energy used for the lithotripsy. Also, the laser lithotripsy is efficacy but take a longer time than the pneumatic lithotripsy. At the limitation of the use of the pneumatic lithotripsy in the mini perk, so it takes the factor to make the mini perk use the longer time of the operation. Mini PNL and also that standard PNL operative time is longer compared with the standard PNL. So for the bleeding and also hospital stay and scar, significant less bleeding complication and hospital stay in the mini perk, and also shorter hospital stay, the size and number of PNL track, the dilatation method is the important factor to causing of the intraoperative bleeding. And the scar between 30 Fen and the full 15 Fen is not different. So my take-home message is my slide, the last slide. Mini perk reduce morbidity of the procedure of PNL at the same time, favor of the same stone fillet and more cost-effective than flexible US. Personalized approach to patient base of the various patient and stone-free factor to provide the best available technology for the treatment. Stone burden and key factor for the safety and efficacy. Smaller is not always better for the selection of suitable cases. It's very important. Need to high quality RCT among mini perk to define the indication for the stone treatment. So thank you again for the organizing committee to invite me to join the session of UROFAIR this year. So this is a picture of the Faculty of Medicine Chiang Mai University. Welcome you all the time to Chiang Mai University, and thank you again for the invitation. Thank you very much.
Hello. Thank you, Professor Banakit. For those who are not aware, he's Dean of the Medical Faculty at Chiang Mai University. We will save the questions to the end. Our next lecture is timely because with the introduction of new laser technology in the last couple of years, sometimes we get confused with regards to settings and strategies with regards to laser energy for urolithiasis and endourology. To address those concerns, our second talk will be given by a good friend of us, Professor Ben Chew. He is professor in University of British Columbia. He graduated in 1998 from University of British Columbia, did his endourological fellowship with Professor John Denstedt in 2003. His practice focused on both medical and social aspects of urolithiasis. He's obviously a world leader in endourology, and he currently leads the research for the Society of Endourology and the World Congress of Endourology as well. He's also the lead for ITCH Research Consortium, which is a multi-center, multinational research arm with regards to urolithiasis. So without much further ado, we invite Ben, who unfortunately tested positive at 5 p.m. last night. He managed to do his recording, and he'll be joining us for Q&A from afar, but we managed to record his lecture last night. So take it away, Ben.
Thank you very much. I'm coming to you from the Gen Singapore here on Orchard Road. I'm sure you've all heard I've tested positive for COVID. I'm doing fine, thank you. I just had some body aches yesterday, and I hope to all the people that I've talked to in the last few days that you're feeling okay. I'm glad I've been wearing a mask the whole time. So anyways, for my final lecture, thank you again for this really kind invitation to be here. I've really enjoyed being here, and I just wish I hadn't gotten COVID. Anyways, we're going to talk about optimal laser strategies, and these are all my disclosures, and the ones highlighted in yellow are the ones that may be relevant to this particular talk. So there's a multitude of new lasers, and I think one of the things is the new laser technologies, and that's high-power holmium with pulse modulation as well as thulium fiber laser. And I think one of the questions you need to ask yourself is, what will I be doing with this laser? What will everyone in my hospital be doing? Are we going to be doing stones, upper tract urothelial carcinoma, as well as prostate? So I think depending on what you want for that, I think that sort of dictates what kind of laser you need. I am basically just going to focus on stones because that's my main focus, but this talk is just basically on stones. So the other disclosure I have to make is that with my previous engagement with Olympus, I was helping them when they were developing the Saltiv laser, and along with Dr. Traxler and everyone else. So I definitely have more experience with TFL. We just got the Moses, so I don't have as much experience with it, but I'm going to try to give you a balanced view of what's in the literature, as well as my personal views of what I've used it for. But just please keep in mind that I have much more experience with TFL. So one of the optimal laser strategies we often ask ourselves is, should I go ahead and basket this stone out, break it into fragments, or should I go ahead and dust them first and then let the pieces pass? So we tried to answer this question from the EDGE Research Consortium, and for this one we basically looked at patients who were prospectively who were either dusted or fragmented. Now remember, this is back in 2018, so this would have been without pulse modulation, still high power holmium, but without pulse modulation and definitely not without TFL. So one could argue that this data is really actually old now, and I think it is actually because it's older technology. Just to remind you that basically, unfortunately, our dusting group had larger stones, on average about 3 millimeters in one dimension, but as shown during this meeting here, that certainly that can lead to different sizes and different volumes. So with that, there was actually a bit of a higher stone free rate with the basketing group on univariate analysis, but this turned out to be no different on multivariate analysis. And of course, basketing took longer. It was much shorter to actually go ahead and laser the stones into dust than it was to basket them out. So what are the things about holmium YAG? And one of them is that it requires a bit of a larger cooling system, obviously, because it's 3 or 4 30-watt lasers in there, which creates a 120-watt laser. And part of it is because there's the beam profile that you have to use fibers that are greater than 200 microns. And, you know, there's some, not limitations, but you can go 120 hertz only, and you basically have a little bit of fragility with the mirror, so be careful moving it around. You need special high amperage outlets for it. So without pulse modulation, this is me with my original low power Homium machine. You can see that there's a little bit more retropulsion. It's not maybe as fine dusting as we have now with today's lasers. So with that, Luminous has come up with what they call the Moses technology, and I think we heard Dr. Ghani talk about this Khurshid Ghani talk about this really well, and he prefers the Moses distance. And this stone stabilizing technology fires 2 pulses, the first one to sort of part the water, and the second one then gets absorbed more by the stone. Now, this can be an upgrade to existing P120 systems, and we talked about the distance versus the contact, and it actually has been shown to definitely reduce retropulsion and improve efficiency as well, too. Joel Teichman, who's also at my university, who is one of the real pioneers in lasers, has talked about what it would be great to have a laser with very low pulse energy, very high frequency, like a gazillion, and a wide pulse width. And this would be the ideal dusting laser. So with that, the thulium fiber laser actually really does fill a lot of these and fit a lot of these criteria, as you've seen. And we talked the other day about how the Homium is about 2120 nanometers. TFL is a little lower, down at 1940, which is closer to the absorption of water. And this leads to a couple of things where it's a bit more coagulative. If you end up lasering the kidney by accident, you're not going to get into those bleeders as easily. It's also the same thing when you're doing a laser enucleation of the prostate as well, too. But what this really has done is it's really tilted the balance in terms of basketing. The dusting factor is much higher with thulium fiber. This with the old Homium and the old high-power Homiums, pop dusting was never really that efficient. And I think with TFL, and I think also too with Moses, I think pop dusting has certainly become a lot more efficient. So instead of that, when you look at the fragmentation with TFL at 0.6 and 30. The first thing that I like to do with this is, this is part of the thing I was telling you about with the disclaimers, that I'm going to give you my experience with TFL, and I have little experience with Moses, and I think we got a really good view of that from Khurshid Ghani. But what I like to do is to break this up into chunks inside of a calyx, and I prefer to do it in a calyx rather than a renal pelvis, breaking it up into pieces and doing that at about 0.6 and 30. And then once you get it into pieces, keeping it in a calyx, and then basically pop dusting at 0.1 and 200, maybe 0.15 and 200. I like to keep it below 30 watts in the kidney. And remember to take breaks. Don't just sit on the pedal the whole time, because that will really heat up the irrigation. The irrigation, I do like to use either room temperature or cooled normal saline. And if possible, you should use an access sheath to help the fluid go in and then to come out as well too, so that essentially you can really keep that kidney cool to prevent any kind of thermal damage. And there have been a few reports, as we've heard about previously in this Congress, about a couple of basically heated kidneys from lasers. So when there is some data, and this was a prospective randomized trial looking at TFL versus the Homium, but the Homium, we have to say, is not the Moses. It's a low power 30 watt. And definitely with TFL, the ureteral stones was a very high stone-free rate of about 100%. But with the kidney, it was actually much lower with Homium, about 49% versus 89% with TFL. Operative time, again, shorter with the TFL. Remember, though, this is not against Moses. So this is also just a head in print as well, too. And this is looking at the outcomes in pediatric patients. And again, very similar, that there was a significant increase in stone-free rate with TFL versus Homium. Again, not Moses, so we have to keep that in mind. But the operative time wasn't any different here. Now, this group actually went and did a bit of a cost analysis, basically just based on operating times. Again, this is in print right now, and what they found was that TFL was on average about 13 minutes faster. And the smaller the stone, the faster it was. And then they calculated it with a certain amount of time that it would result in this amount of savings per operative costs. This may not be in every type of medical system, but certainly we do know that operating time and people costs are certainly one of the higher costs in our operating facilities. So Joel Teichmann and this other group here looked at what the mechanisms were when you did pulse modulation. So this is using Moses. And what they found was that most of the effect is photothermal. Some of it is photoacoustic. And this again is just ahead of print and e-published. So what they found was that, again, much higher peak pressures if you didn't use pulse modulation. So good to confirm that. Certainly there's much higher, almost 5 or 6 times higher peak pressure if you don't use Moses. So that stone is going to really jump around quite a bit. And then Khurshid Ghani looked at his first 12 patients and actually published this. And he found that the complete stone-free, so stone-free was about 82%, but those less than 2 millimeters was 18%. So really, if you're looking at a success rate of less than 2 millimeters, it's really actually 100%. And these are his preferred settings on Moses 2.0, and he prefers the distance setting. Again, he looked and published on a series of 29 patients with a solitary stone, and looked at certain size stones. And again, the mean time of lasering time was only about 6 minutes. So his efficiency is really quite amazing. The fragmentation speed of about 0.9 cubic millimeters per second. And this is a really interesting study by Mahesh Desai's group. They looked at mini PCNL stones in patients less than 3 centimeters. High power homeomyag with Moses versus TFL. And what he found was no difference in stone-free rate, both at 48 hours in either group. Stone fragmentation rate was actually pretty good, and definitely faster than when you do it ureteroscopically. There was no difference in total laser energy. So I thought this was a really nice study to show that with Moses and with the TFL, we're actually seeing very similar effects with mini PCNL. I think the study we obviously want to see is Moses versus TFL in ureteroscopy. There are a few groups who are looking at that. So a couple things I just want to talk about compared to for TFL is compared to the old homeomyag. It's very good at dusting. I think the new Moses homeomyag is also very good at dusting. My experience with TFL is actually very hard to fragment the stone. So if you are a basketer, I think you may find it a little bit more challenging. It's hard to break it up into those big pieces, and you don't get that retropulsion and the high peak powers. And sometimes, in fact, you want that retropulsion, you want that fragmentation. I talked about it on Thursday, how you want almost sometimes a little bit of side firing for impacted stones in the ureter, stones in a calyx which are slightly off that you can't quite get straight onto, and stones in the lower pole. So for instance, this patient here with this large partial Staghorn calculus, Hounsfield units over 1100. When I use this, my scope couldn't really quite get to the stone, and I wasn't able to basically fire directly on it. So at some point, I'm actually getting very, very inefficient. It's not this part, but what you'll find here is I just can't get a straight shot. I can only get to the top of the stone. And because the TFL is such a small beam that is very coherent, I really wanted a little bit of more high peak powers and high peak pressure. So what we ended up doing was we ended up actually switching to the homeomyag to 200 micron fiber, and even just at settings of 1 and 10, because this is my low power 30 watt laser that I have in our stone center. I was actually able to reach the stone a bit more because I almost wanted a bit more of that side firing. So this is just something to keep in mind, that you may want some of that side firing. And then I broke it up into chunks. Once I fragmented into bigger pieces, I got it into a calyx. And then I finished it off with TFL because my TFL is a better pop duster than my low power Homium. Again, I don't have that same experience with Moses, but it sounds like people like Vineet who are here can tell you that that would give you a very similar effect. And in fact, he almost prefers that sometimes. So, you know, I think that, again, my disclosure, so my whole talk has really been based more on TFL than with Moses. But I think the main thing is use what you are comfortable with, but learn what you are using. Please speak to the reps, speak to other people who use that laser, and learn the limitations of it. Learn what settings to use, because right now we don't have a superior laser. And before, you know, we really talked that from our study, dusting is equal to basketing. And in these new lasers, they really, really dust quite well. And you really have a hard time fragmenting almost, unless you turn off the Moses and Homium. So you can still do that. But no matter what kind of energy you use, please be careful of the heat that is generated. You can cause thermal injury, particularly to the ureter and even to the kidney. So that's cooled irrigation, use of a ureteral access sheath. Try to keep the energy as low as necessary. Don't overcrank it just because you can. You don't go driving your car at 200 kilometers an hour down the street just because you can. You must adhere to the speed limits. So again, I want to thank you, and I'm really sorry I'm not there today. I just want to tell you about when the next World Congresses of Endourology are. And again, thank you very much.
Thanks, Ben, for that wonderful recommendations. If an expert endourologist tells us to be careful with some of these new technologies, then I guess we better listen. We'll hold the questions until the end of the session. The next speaker is Dr. Manin Usawa Chinmatachit, who's an attending urologist from King Chulalongkorn Memorial Hospital in Bangkok, Thailand. His clinical interests are in minimally invasive surgery for urinary stone, laparoscopic surgery, and pediatric stone disease. He's also a member of the Endourological Society, the AUA and the UAA. And his talk today will be on single-use versus reusable flexible uteroscopy. Please go ahead.
Good morning, dear audiences. First, I would like to thank the Scientific Committee of the UROFAIR 2022 for inviting me here. My name is Dr. Manin Asawatinatit from King Chulalongkorn Memorial Hospital in Bangkok, Thailand. And today, I'm going to use my 10 to 15 minutes to give you a brief review about the single-use versus reusable flexible uteroscopes, sharing the experience in Thailand. Briefly about my hospital, the King Chulalongkorn Memorial Hospital. This is a university-based tertiary care hospital with over 1,400 beds. It was located in Bangkok, Thailand, in the central area. It was established in 1893, and it is affiliated to the Thai Red Cross Society and the Chulalongkorn University. And for our division of urology, we have 9 attending urologists and 23 residents in urology. First, I have to say that the management of stone with URS is increasing. There is one review from Canada. They show that in stone cases, the use of uteroscopy increased from 25% to nearly 60% in 2010. This comes when a significant wear and tear of the scope, which is so delicate. There is one pain point of reusable flexible ureteroscope. Besides the purchasing cost, which is very expensive, there should be the cost associated with the scope repair, the cost associated with the reprocessing, and also the cost of OR delay from reprocessing or repair process. And of course, there is a theoretical device contamination risk. So regarding the repair, there is one review from Landman into early 2000. They used the combined data approach with the cost data and the durability data. The cost to acquire and repair a reusable scope after 1 year warranty expiration for the use of 100 cases should cost around almost $60,000 US, which is a lot for some countries, especially in the developing country. Regarding the reprocessing, there is one review from Isaacson and G at UCSF in 2017. The researchers have used a time-driven activity-based costing model And they revealed that the reprocessing costs include the labor, the time, and the disposable items, in which the reprocessing time may be around 200 minutes per unit of the scope. And the reprocessing cost of the unit should be around almost $100. What about the device decontamination? There is one study from Legimet and Delarose in 2019. They utilized the microbial samples of the uteroscope shaft and working channel after the reprocessing, almost 400 procedures. And they found the positive culture in 12% of the scopes, in which they revealed the uropathogen in 2.3%. However, there are no symptomatic UTI from the uropathogen contaminated scope. So this brings the key concept of utilizing the single-use flexible ureteroscope. Besides, we divided the purchasing price of the scope into multiple fragments. We can omit the repair, we can omit the reprocessing and the cost of the delay, the OR delay from reprocessing or repair, and we can delete the risk in theory of the device contamination. In 2016, Boston Scientific from the USA already launched the LithoView, which is the first fully disposable single-use flexible ureteroscope. And after that time, there are so many devices launched from different companies. Herein, I reviewed the timeline of the flexible ureteroscopes available in Thailand. In 2017, at that time, we already have 3 types of the reusable scopes. The one from Olympus, the next one from Kaustos, and the last one from the Richard Wolf. And at that time, we already have the Boston Scientific LithoView available in Thailand. And 1 year after, we got the Fusen U-scope from China in 2018. 2 years afterward, we already have the Anting U-scope also from China in 2020. And last year, in 2021, the Olympus just launched the new model of their scope, the Olympus URF-V3 into the Thai market. And at the same time, we already have another brand of the single-use ureteroscope, the OTUV scope, also from the USA. And earlier this year, we also have the ZPL scope from USA and the Cyvita SUV scope from China. This table summarizes all the single-use flexible scopes available in Thailand. I just summarized all the data last month. Here you can see that besides the scope from USA, the Boston Scientific LithoView, the OTUV scope from USA, and also the ZPL model from USA, we have a lot of models of the single-use scope from China, especially the Fusen, the Innovex, Anting, and also the Hugemet and the Cyvita from China. Whether to use the single-use or reusable scopes in Thailand remains debatable, and there are so many theories, there are so many reasons that we have to explore. And herein, I'd like to share you the experience from Thailand, which is a developing country. Briefly about Thailand, here is the fact sheet of the Thailand in urology perspectives. We have a total population of the country of 66 million people. The GDP per capita is around $7,500 US, which is categorized as a middle income country. We have the number of medical doctors for the whole country of around 60,000 doctors. And for the urologists, we have almost 600. And the incidence of urolithiasis in Thailand, the number is around 100 per 100,000 inpatients from stone disease. The incidence of the reusable scope breakage, herein I summarize the data from Thailand. There is one review from Hong Vibunet in 2019. They utilized the durability study in a single academic center, in which they used 6 flexible uteroscopes from Olympus, and they performed almost 500 cases in 3 years. And they revealed that an average of 32 cases to scope failure, in which the most common reasons for the scope failure may include the working channel leakage and the deflection mechanism failure. Consideration for flexible uteroscope acquisition should be so many things that we have to look at. Maybe the case volume, the hospital service setting, the surgeon experience, the reprocessing facility, and the scope handling, and the healthcare system policy. For the case volume, I think that single-use flexible uteroscopes may be more suitable for low-volume centers. There is one study from Martin and Humphreys in 2017. The author utilized the cost-benefit analysis over a 12-month period with a total cases of 160 and an average of 12 cases to scope failure. And at the end of the study, they revealed that after 99 cases, the cost-benefit analysis favor reusable ureteroscope, so that you may utilize the single-use flexible uteroscope in a low-volume centers, which is more suitable and appropriate. Regarding the hospital service setting, for the private sector, there shouldn't be any limitation in using the single-use ureteroscope. But for the public sector, especially in a provincial hospital or in a medical school, and also the urology training center, in which there are so many residents who have less skill and experience in scope handling. And so probably the training with a single-use scope exclusively may be more appropriate. What about the urology training in Thailand? I have to tell you that in Thailand, we have no board-certified Endourology fellowship training. And for the residency program in urology, we have a 4-year program and with 30 residents per year from 11 training centers. And for the skill training in flexible uteroscopy in year 2 of residency, we usually give them a hands-on training in a model. And in year 3, they're usually supposed to have 3 to 5 cases under supervision. And on the last year, the year 4, they usually are able to perform maybe 10 to 15 closely supervised and unsupervised cases. The third thing is about the surgeon experience. There is one systemic review from Phuket and Ahmed in 2018 to try to figure out the learning curve of flexible uteroscopy. And the authors found that 60 cases for operative time and about 56 cases for fragmentation efficacy. So the learning curves in flexible uteroscopy is supposed to be around 60 cases, which is a lot. And some surgeons may have to perform this kind of procedure for almost a year to achieve that learning curve. The fourth thing is about the reprocessing facility and the scope handling. There should be a dedicated reprocessing facility and staff in handling the delicate flexible uteroscopes. They have to strictly adhere to the manufacturer instructions. There should be some staff committed to carefully reprocessing, and the scopes, all of the scopes should be stored in a sterilized containers in a straight or lightly curved position. And one thing you have to mention is about the OR delay from reprocessing process if there is no such facility in place in the hospital. The fifth thing is about the healthcare system policy. The system in Thailand is so complicated. Besides the private health insurance, our national healthcare system consisted of 3 parties. The first one is the Social Security scheme, in which cover the employers and employees around 16% of the total population. The second scheme is the Civil Servant Medical Benefits Scheme, which cover around 8% of the population. And the third one is the Universal Health Coverage Scheme, which cover almost 90% of the population. And each scheme has a different policy in the coverage of the medical expense. For the civil servant medical scheme, they usually fully cover all the costs and also the private health insurance. But for the Social Security scheme and the Universal Health Coverage Scheme, they just partially cover the cost of some single-use devices. The cost of single-use devices not covered by some schemes may include the uteral access sheet, the basket, the stent, and also the single-use flexible uteroscope. So in some patients in Thailand, they are required to co-pay the expense of the flexible uteroscopy, which may ranges from 500 to $1,000 US, which is a lot in some developing countries such as Thailand. So the policy of acquiring a flexible uteroscope, I may talk about 3 types of the policy. The first one is to just use the reusable scope, which is more suitable for a high volume center, which perform more than 100 cases per year with highly experienced urologists. Some institutions may acquire just a single-use scope, in which I think is more preferable for low volume center, which perform less than 50 cases per year, and for the private sector. And some institutions may use the mixed strategy, which is more preferable for the high volume center, which perform more than 100 cases per year. But there is some training in urology, the residency training, or there are some mixed experienced urologists. In King Chulalongkorn Memorial Hospital, we perform around 120 to 150 cases of flexible uteroscopy per year. And we also have the residency training. We have 2 attending urologists specialized in endourology. And so we have adopted the mixed strategy since 2019. There are 2 reusable flexible uteroscopes available in our hospital, which have a reprocessing time of around 120 minutes. And we also have single-use flexible uteroscopes on shelf, which is available all the time. Some situations may be more preferable to utilize a single-use ureteroscope. That I can tell you, in some cases with large kidney stone more than 2 centimeters, In some situations with lower post stone more than 1 centimeter or steep infundibulous pelvic angle. In some cases with kidney anomaly or more rotation, and of course, in the case in which you will assign your urology resident as a primary surgeon, I'll prefer to use a single-use ureteroscope more than the reusable one. Last thing I have to mention is about the reuse of the single-use flexible ureteroscope, which is utilized in some developing countries. There's one study from Adhit Curry in 2021. This is an observational study. They utilized almost 38 single-use ureteroscopes for almost 200 procedures. So that means one scope for 5 patients, and the mean operative time is around 44 minutes for each case. For the reprocessing process, they utilized the immediate manual cleaning and flushing with water and povidone iodine. Then they allow the scope to dry in the room temperature. They repack each instrument separately, and before utilizing in the next patient, they can sterilize the scope with glutaraldehyde solution for 20 minutes. And at the end of the study, the authors found that there are immature scope damage in 9 scopes, and 5 patients, or around 3%, developed UTI after the procedure. And the authors concluded that reprocessing and reuse of the disposable flexible ureteroscope is probably safe and cost-effective. There was minimal probability of the cross-infection and the immature scope damage. But they have to say that this is just in case when the reprocessing process is well supervised. However, at the same time, there is another study from Chile, from Dominech. The authors analyzed the pre- and post-operative images of the instruments used in 23 flexible ureteroscopy, comparing between the reusable one from STARS and the single-use one from Hussein, OTU, and Littlefield. Interestingly, all the single-use scopes present more damage on the distal tip, in which you can see in pictures on your left-hand side. So the authors concluded that the reuse of the single-use scopes in documented real life would compromise an adequate sterilization and patient safety. So in summary, whether to utilize the single-use or reusable flexible uteroscope depends on several factors, mainly the case volume and the surgeon's experience. No particular single-use flexible uteroscope has a clear advantage. So it depends on cost, individual factors, and institutional level factors. And lastly, surgeons should be familiar with the particular strengths and weakness of the devices. And I thank you for your attention, and I'm happy to answer all the questions.
A very big thank you to all 3 speakers as they touch on hot button issues in endourology. At this point in time, we'd like to open the session for any questions from the floor. Maybe I start off with a question to Professor Banakit. How are you doing, sir?
Michael, I'm fine. Thank you very much. And how are you?
See you. So you have listed in your indications for mini PCNL, mostly cases that you find difficulty doing RIRS. That's what I noticed in your slide. My question to you is that currently in your practice, if you are facing with a straightforward 1.5 centimeters low post stone, what in a normal anatomy, would you be going RIRS in view of the technology advancement, or are you going to stick to mini PCNL? What's your current practice and why?
So Michael, I think right now we have more and more cases of the RIS. So I think that the first choice is the RIS. But for mini PNL is maybe the second choice for me. But I would like to say that because we are the medical center for the training also, we have to treat the resident to do the mini perk right away. Because when they graduate from the medical university, they have to go to the rural area. So I think it's better they can perform the mini PNL also. So I think that for my first choice is the RIS, but second choice is the micro perk or mini perk. But I think both of them can learn that equal of the. I think if the stone is not bigger than 2 centimeters, I think the result of the both technique are the same. So my point is the RIS is the first option for me.
I'm sure the other 2 speakers also agree with you. Ben, a quick question. So you're now acquiring the Moses technology and you're going to compare it with TFL and Moses. At the end of the day, is your choice going to be which has the lower maintenance, which company has the best post-sale service in choosing the 2 laser fibers moving forwards? if we assume that all the data coming through is going to be quite similar in the same bandwidth with regards to efficacy, is that going to be a key choice for you moving ahead?
That's a great question, and it's so variable in different places. But I do think that I think the costs are actually very similar. At least they are in Canada, and it also depends on what kind of commitment you already have with each of those companies. And now that the Moses is going to be with Boston Scientific, I think that's going to make pricing a little bit different because they have such a wide range of materials. So I think that varies from place to place. Cost-wise, it won't be very different at all. I just wanted to touch base with your lower pole stone. If it's a really severe angle, I often don't like doing ureteroscopy. I'm sure you find that when it's a really difficult angle to reach down, you can't get to there. So sometimes in those, I will try to tell people that perhaps a mini perk might be better, even for a 1 centimeter lower pole stone. That's one of the suggestions that I would have.
I think someone has got a question. Hello, can you hear me? Hello.
We can hear you.
I have a question for Prof. Banakich. Thank you very much for your talk and Sawadee Cup. I would like to ask you your experience with mini perk. Now we talk about the RIRS with suction, which is going to revolutionize stone-free rates. What is your experience with mini perk using suction devices rather than just the vacuum cleaning effect? And from what I understand, there are actually mini perk access sheets that come with suction, or even lithotripsy devices that come with suction for the mini perk. Any experience there?
So I think thank you for your question also, because we have the instrument from China, from Guangzhou Reprocessing, that they are available in Thailand right now for the suction also. So I think that maybe that they have a new model for the suction and also the vacuum effect. First of all, for the mini perk, we usually rely on the vacuum effect that but right now for the suction, they have the operative time is shorter and also is safe also, because I think that they say the complications such as fever and also that sometimes they have some complication is late in the suction also. So I think right now they have the technology for the suction with the mini perk. So I think it's the way to go in the future. So I suggest that for the new model of the mini perk, they have more and more technology for the suction. I recommend that they have more and more chance of the instrument come now.
Thank you. And just one more question for Prof. Manin. Thanks very much for your talk on the single versus reusable. We also struggled with that question to find the right combination. But I'm just thinking, for a country like Thailand, I mean, you have state-of-the-art equipment in the big cities, but in your district hospitals, wouldn't a mini PCNL with a low power laser be actually much more cost effective than RIRS with a high power laser?
Yeah. I would agree. In the low volume centers, such as the center which perform maybe less than 50 cases of flexible URS for 1 year, I would prefer to get the mini perk with the laser lithotripsy done because I think it's more effective. Maybe it's more cost effective than using the flexible ureteroscope. Yes.
Another question on reusable ureteroscopies. Have you found in your experience with all these different kinds whether there's a big difference in visualization in all those single-use URS that you've used?
It's getting better. I mean, the visualization of the single-use scope compared to the reusable one. And I have to say that each brand or each device of the single-use flexible ureteroscope has a very kind of different visualization comparing between one brand to the other brand. And it depends on the surgeon. So we should try it before using in a real patient. And decide which one we should use in the hospital.
Any other questions from the audience?
Can I make a comment on the single-use scopes? Maneen, great talk. One of the things that I found when we got the single-use scopes in for the residents was that the ones that were training before with the reusable scopes were always handling it very carefully and very nicely. And then when we had the single-use scopes come in, and then some of the other younger residents learned how to do that, I noticed that when they then went to use a reusable scopes, they weren't as careful. They didn't realize how fragile it is. So that's one thing I caution, is that because they start, just moving it around. Oh, here you go, and they throw it and everything. So I think just be careful. I do agree, though, if they're just going to do a case on their own and you're just going to watch, it's a good one. But I think that they may not have that same appreciation if they learn with something that is not very fragile.
Sorry, I just have one comment. Thank you. Great presentations, Dr. Manin and Dr. Ben. Either of you can take this. Do you think single-use scopes really, really help ergonomics in RIRS? To ergonomics, do you think this is really one area where probably it helps you to do bigger stones, not necessarily faster, but at least bigger stones? Because Prof. Traxia and me we've had this paper together, and we feel that probably it contributes.
I would agree in terms of ergonomic, because the single-use one is much lighter.
Mm-hmm.
I would agree that.
Mm-hmm.
Yeah, I also found maybe the handle, the way the companies are improvising probably also helps in handling of the scope as well. Yeah, thank you.
Well, we have the caller. And any other questions before we close the session? If not, it remains for Professor Noor Azari and myself to thank Ben. Ben, please get well from COVID-19. And for our two Thai professors, Kap Pum Kap. And we end this session now. Thank you very much.
Thank you.